Hello friends, welcome to my series of PGI question discussion. Today the first session of discussion. All these questions I have taken are from the previous PGI exams. The first question is true about rhabdomyolysis. So the options are given in front of you. So let's learn some basic concept about rhabdomyolysis. This typically occurs in the setting of earthquake. When the earthquake comes, buildings fall. It's quite possible that some big chunk or some big building material falls on the thigh of a person, and the thigh muscles are crushed. And as the thigh muscles are crushed because of heavy pressure of the building material, and if the rescue team come after maybe few hours and the person is rescued, but during that time when his thigh muscles are under great pressure, they all get broken down, they are converted into urea and creatinine. And remember, as long as he is under the pressure, the urea creatinine are just confined to that area only. But once the pressure is released, suddenly a high amount of urea and creatinine goes to the circulation. And in that time, even patient may be passing a large amount of urine. Still, as the solute load is very high, he is not able to excrete the whole urea and creatinine. That means at that time he is passing maybe a liter or 2 liters of urine, but still the solute load is very high, and this even 2 liters of urine output is less enough to excrete whole. That's why we call the term as non-oliguric renal failure. Well, the other features what we see in this rhabdomyolysis is hyperkalemia. Why hyperkalemia? As we know very well that potassium is mainly a intracellular ion. As the cells are crushed, the potassium comes out into circulation, again hyperkalemia. Hypocalcemia occurs because this calcium get bound to phosphate. Hypocalcemia, not hypercalcemia occurs. And due to breakdown of large amount of muscles, lactic acidosis occur and hyperuricemia occurs. So other than option B, everything happen. So hypocalcemia is a feature, not hypercalcemia. I think this is a very important question. In fact, same question come about tumor lysis syndrome also, which typically is seen in the setting of when we are giving chemotherapy to a patient suffering from any tumor, especially leukemias. The findings are same as I discussed just now. But remember, in rhabdomyolysis, which I told you especially occur in a setting of earthquake or any other condition which can lead to extensive muscle breakdown. But I gave you example of earthquake. Now tumor lysis syndrome, as I told you, occur typically in the setting of chemotherapy. So as chemotherapy is well planned, and we know very well that once we give a chemotherapy, especially in leukemias, large number of cells will die and they will produce a large amount of uric acid, which can precipitate gout, or it can even precipitate some uric acid stones, or it can lead to interstitial nephritis. The rule is, before we are planning for chemotherapy, patient should be given high amount of hydration, and the allopurinol should be started 48 hours before we start chemotherapy, and that is again to prevent the effect of hyperuricemia. So the answer of question number 1 is A, C, D, E, as I discussed just now. Question number 2, hyperkalemia is caused by, well, let's learn the basic concept. Normal serum potassium is 3.5 to 5.5 milliequivalent per liter, and if the level is more than 5.5, then we call it to be hyperkalemia. The causes are, first of all, any cause which lead to acidosis. This needs discussion. Why hyperkalemia and acidosis occur together? Let's learn the basic concept. This is the blood vessel, and here is the RBC, and we know very well potassium is an intracellular ion. Whenever acidosis occur in the body, large amount of H ions are being produced. During acidosis, lungs and kidney play a role, and they tend to bring the pH to normal by the concept of compensation. But that is known to most of students, but some of the students, they don't know even RBC play a role in acid base control. How come? So during acidosis, this H ion will enter the cell. Now a positive particle has entered the cell. As per law of electrostat, one positive particle has to come out. The H ion will come into the cell and potassium will come out of the cell. So that's why acidosis are usually associated with hyperkalemia. But in medical science, there is nothing like absolute. Now come the classical question, that point which will fetch a seat, top rank seat for you. What are the conditions where we have acidosis with hypokalemia? Note down. The conditions are RTA type 1, type 2 and severe gastroenteritis, that is diarrhea, especially diarrhea, severe diarrhea, gastroenteritis, which can lead to metabolic acidosis with hypokalemia. Friends, this is a top rank getting question for you. So now you understood why acidosis will lead to hyperkalemia. Well, the other condition, but remember, in vomiting is hypokalemia occurs. Same with diarrhea also, hypokalemia occurs despite having acidosis. Now hyperkalemia occurs in Gordon syndrome and cyclosporin. In Bartter and later also hypokalemia occur. Now other drugs which can lead to hyperkalemia are ACEI. I think this question come every year in all the exam. Heparin and NSAID. Okay, these are the other important drugs which can lead to hyperkalemia. So the answer to this question is Gordon syndrome and cyclosporin. Now I like to add, because hyperkalemia is a very important question, so I like to discuss more. Hyperkalemia, the one topic practically always about this, there is something or other thing in all the exam. So I discuss the causes. Now let me discuss what are the clinical feature of a case of hyperkalemia. In hyperkalemia we get muscle weakness, we also get cardiac arrhythmias. Now in the treatment, first of all, in severe hyperkalemia we always give injection calcium gluconate. It stabilizes the cardiac membrane and it prevents arrhythmias. It does not reduce the serum potassium level. To reduce serum potassium level, we use injection dextrose, insulin drip. It is the fastest, easiest and the best way to reduce serum potassium level. What is the basic principle? This is cell, when glucose enters the cell due to insulin, it takes potassium as a co-transport. That's how we use dextrose insulin drip to treat hyperkalemia. Second way of treating hyperkalemia is by giving beta 2 agonist drug. Most commonly used drug is albuterol. In actual practice, we can use salbutamol also. Okay. Now, one thing I especially like to highlight: injection soda bicarb has no role in the treatment of hyperkalemia. And perhaps many of you will not agree with me, well, because at times people do read low grade guides which give you wrong answers. Now, to verify my statement, because you need verification from which this statement has come, you read Harrison 19th edition, latest edition. You read page number 312, pages like this, Harrison, and it has got two columns, left and right. On the left side, second paragraph from the bottom, the first line, it is written, soda bicarb has no role in the treatment of hyperkalemia. I think I cannot give a better reference than Harrison 19th edition. So friends, to treat a case of acute hyperkalemia, we give injection calcium gluconate, we give injection dextrose, insulin drip, we give beta 2 agonists. They are the three things for treatment of acute hyperkalemia. Dialysis we can use for both acute and chronic hyperkalemia. But potassium chelating resin we use only to treat chronic hyperkalemia. Potassium chelating resins are never given in acute hyperkalemia. Question number 3, about third sound. Okay, so before I discuss third sound, let's learn the basic concept about normal cardiac cycle. So this is the heart. So when diastole start, these mitral valve and tricuspid valve they open, and rapidly blood enters into the ventricle, and in fact around 70% of the blood come from atria to ventricle, and this is known as rapid filling phase of myocardium. And in that phase, on the right side in the JVP we get wide descent, and on the left side in the left ventricle normally we do not hear any sound, but if a sound has to come, it is third sound. That's why third sound is also known as filling sound, because it is heard in the rapid filling phase of myocardium. So now you understand that wide descent is correspond to third heart sound. Now near the end of diastole, this atria contract, and that pushes another 30% of the blood into the ventricles, and this is known as atrial kick. During that time in the JVP you get A wave, and on the left ventricles normally we do not hear any sound, but if a sound has to come, it is S4. That's why S4 is also known as atrial sound. And now I don't need to tell you that A wave will correspond to S4, and we have already learned that wide descent correspond to third sound. Now I don't need to tell you that in atrial fibrillation there will be no A wave and there will be no S4. Okay. Well, S4, now what are the conditions where we hear the third sound? It can be heard normally in children, it can be heard normally in pregnancy and in athletes. Pathologically, it can be heard in congestive heart failure, mitral regurgitation, in AR. Okay, it can be heard in AS also, HOCM also. But two things where S3 is never there, this is again a top ranker question. The two conditions where third sound is never heard is mitral stenosis and cardiac tamponade. It is heard in constrictive pericarditis, where a special name is given, so-called pericardial knock. In fact, one question came like this also in the previous PGI exam. The pericardial knock is seen in which condition? The answer is constrictive pericarditis, which is nothing but a third sound which is seen in CP. So in MS and CT, third sound is never heard, and it is a low pitch sound. Okay. So now let's see the answer. True about it is heard in MR, yes. Is it diastolic sound? Yes, rather it is the early diastolic sound. High pitch? No, it is a low pitch sound. Normally in children? Yes. Correspond to wide descent? Yes. Question number 4. True about myasthenia gravis. The options are given in front of you. So let's read some basic concept about myasthenia gravis. It's a disease more in young females or young female or old males. It's an autoimmune disorder of the myoneural junction. What happened? This is the myoneural junction. This is the nerve terminal and this is the muscle end. Here are the acetylcholine receptor, and this is the acetylcholine which is released due to nerve when the nerve impulse come to nerve ending. This acetylcholine will come and get attached to receptor, and this how the muscle will contract. But in cases of myasthenia gravis, they have antibodies. Acetylcholine receptor antibody, they block all the receptor. So even when the acetylcholine comes, the receptors are already blocked, so they are not able to bound the postsynaptic receptor, and this is how the muscle become weak. Classically, the patient has evening fatigue, and the patient has diplopia, ptosis is a feature. Okay, and one more thing, a thymoma may be there with this patient, but or sometimes thymic hyperplasia can be there. And the single most important diagnostic investigation is EMG. Again, some confusion. Many guides they write adrophomium test as the most confirmatory test is the wrong answer. Most confirmatory is EMG is the most confirmatory. Okay. In the treatment of acute myasthenia gravis, we can use steroid or we can use plasmapheresis, which will remove the acetylcholine receptor antibodies. But otherwise, for a routine case of myasthenia gravis, we can give anticholinergic drug like pyridostigmine. What is the role of thymectomy? Thymectomy should be done in all the cases of myasthenia gravis with or without thymoma or thymic hyperplasia. But it is not done in children or above the age of 55, and it is also not done in those cases where myasthenia gravis is just confined to eyes, so-called ocular myasthenia gravis. Otherwise, thymectomy should be done in all the cases. What is the role of thymectomy? Is it going to cure the disease? Not at all. Role of thymectomy is same as what is the role of splenectomy in hereditary spherocytosis. When we remove the spleen in a case of hereditary spherocytosis, patient has symptomatic improvement, but there is no removal of the disease. Same is the hair also. Once we remove the thymus, only there will be symptomatic improvement because that remove the source of T cells, but otherwise the disease will remain as it is. So with this background, true about defected myoneural junction, yes. Increased acetylcholine receptor antibodies, yes. Occur in young male, older female, no, it is other way around. Thymoma occur, yes, it may occur. Autoimmune disease, yes, it is true. The answer is A, B, D, E. Question number 5. NF1. So answer options are in front of you. So let's learn about NF1. It belongs to the category of disease so called neurocutaneous syndrome, which include NF1, NF2, von Hippel-Lindau syndrome, tuberous sclerosis. Okay. And what is common in all these? All these are autosomal dominant. So definitely positive family history will be there. Now NF1, classically there is axillary freckling is there, Lish nodules are there, optic glioma is there, but the most frequently asked question is capillate spot. Capillate spot is practically question come every year. Okay. So if you look at the option, axillary flaking, yes. Seizures do not occur in. Seizure occur in tuberous sclerosis. Optic glioma, yes. Acoustic neuroma do not occur in NF1. They occur in NF2. Family history positive, yes. It will be positive in all autoimmune disorder. And one more thing before I go further. Neurocutaneous syndrome is one of the most frequently asked topic throughout the world. It's very important topic because this question topic come both in dermatology as well as neurology and of course pediatric also. So please read this topic very carefully and more in detail. The answer of this question is A, C and E. Okay. So in addition we have something more for you. We have a UG test series for the undergraduate friends. We have an online PG test series where we give explanatory answer with video discussion also. No other one does like this. We are the only one who give you video discussion also. We have a champion live test series which we do in computer labs where you have actual feel of the exam. We are also launching USMLE step 2. You can see a free lecture on acid base disturbance. You must see this, whichever exam you are writing. This will really clear your all fundas about acid base disturbance. You don't need to read anything else about acid base once you see this lecture. Of course, one more thing, just on this Sunday only, we have a AIMS exam. Again, I am very happy to inform you, 81 question out of 200 question came from our LMRPs, which are the highlight. 81 question is good amount. Even a single question done right and wrong can change the result. And as we are discussing the topic, 20 topic came directly from the last 2 weeks of discussion of our AIMS in our Facebook, and all these books are available on our Flipkart, Amazon and website. In fact, at the end of each chapter of each book we have given LMRPs. You should read those topics and get enriched with a lot of new information. More than 7,000 LMRPs are given. And we have a medicine simplified textbook, mini Harrison. People say, should we read Harrison or not? I say reading one page of Harrison need half an hour. To understand you need 2 hours, and you need only 2 minutes to forget what is written. It is just like somebody asked you, a first prof student says, should I read Gray's Anatomy in first prof? A second prof student says, should I read Goodman and Gilman? What you will answer? No, don't read this thing. You read the basic book. You read Dr. Chaurasia's book or Inderveer Singhji book, and Gray should be read as a reference book. Same thing, this is the mini Harrison. Whatever you read from Harrison is given in this book, and it contains many things which are not given in latest Harrison also. This for undergraduate friends, and this essence is again question bank based on Harrison 19th edition for intern and post intern. Okay, so you can, these books are available on Flipkart and Amazon also. Well, I've got many lectures recorded in the YouTube. You go and see the YouTube channels, Dr. Bhatia Coaching Institute. Lots of lecture on medicine are there, including many discussions are there. You should go and read. And if you want to get directly connected with me, you can send your details to my personal WhatsApp number. I'll be sending you lot of update and last minute revision point. Thank you very much for watching this video. I hope you like it. Stay tuned and my best wishes to you for the PGI exam. After PGI series is over, I'll also do the JIPMER series also. So my best wishes to you, and get connected to me, give me your useful feedback. I'll be very happy to receive your comments. Thank you very much, and may God bless all of you.